Morning, everyone. Can you all hear me? I can hear you. Good morning, everyone. Can anybody hear me? All right. Thank you, Sophia. I appreciate that. We will probably be starting here in another 4 to 5 minutes. I am asking everyone to sign into the chat box. Please put both your name and facility, and we'll use that as our sign-up sheet today.
Yes. How is this possible? My that lady that accepted the evening. Oh.
Does everybody find the chat box? Good morning, everyone. We'll give it a couple more minutes before we get started with our statewide lab partnership call today. Happy Monday. Go ahead, and while you're waiting, please make sure and fill out the chat box and sign in. Much appreciated. Has everyone found the chat box to sign in? Let me know if you cannot find the chat box. Should be right on the ribbon. If your ribbon's not showing, bring your cursor up to the very top of the screen or the bottom of the screen. Hopefully it'll be around somewhere. We'll probably get started in just one more minute. It's Monday. Good morning, everyone. Go ahead and sign in. We'll still give it another minute. I have 12 o'clock straight up, but we will give it one more minute for people to sign in. I know how it is on Monday, so. I'm glad you guys could all be here today too. And some of you I know are on the phone. If you're on the phone, would you just unmute and let me know who it is? I'd be happy to write you in as being an attendant to the meeting. Do we have anyone on
Karen,
the phone?
it's Tony Golden.
Oh, good.
It's Tony Goldenstein.
Okay, perfect. I got you down. Anybody else on the phone? All right. So before we get started, we'll go ahead and just again remind everyone, if you can, please sign in. It's my attendance sheet. Always good to know how many and who is with us today. So welcome everyone to the statewide partnership call. Just basic etiquette. You can mute your speakers, but please don't hesitate to ask questions during the conference here today. If you have a burning question, or if you want, just put it in the chat. I'll try to monitor it, but I've got others who I know monitor the call as well. So it's always good to share faces so we can see each other. If you're shy, I understand, but it's always good to know who we are talking to. We'll go ahead and get started. And just to let you know that the meeting is recorded. It essentially is serves as my minutes. So what I do is I post them on our website every month. This gives people an opportunity. If you aren't able to attend this actual meeting at noon, then you can, of course, pick it up at a later point. Usually takes me a day or two to get it on the website. So watch for that soon if you want to rewatch or have maybe your staff watch it as well. With that, I think we'll go ahead and I always put the reminder out there when we're talking about disease outbreaks that for any request of the state or of CDC, we must have approval by our EPI staff to be able to send it in. So before you just send this specimen, there's a lot of paperwork to do. We would appreciate if just calling us, we could walk you through the steps of the paperwork, and then we can notify the proper people too of what's coming. So we greatly appreciate that if you can reach out to your local health department or the state health department or NPHL, and with that we'll make sure everybody gets the information. So as I look at our list, and thank you everyone for signing in. If you are just getting in late, please do make sure that you sign in your name and laboratory into the chat box. If you're on the phone, let me know later. I'll call for your name later and we'll get you signed in as well. I think I did see a couple of our DHHS staff. Sadie, is Robin here or?
I'm here.
Oh, Robin, good. Good to have you. And how about Matt?
He is not available today.
All right. That sounds fine. Okay. Well, let's go ahead. Is there anything both on the NPHL side, instead of breaking it up between NPHL and DHHS, I thought I would just as a whole talk about the process. So if DHHS or MPHL has any information on
Hi, Bill.
COVID.
This is Cheryl Cavan from Methodist Fremont Health. How are you?
Yeah.
I'm same boat as you, working crazy shifts, no time in my office. I'm multitasking. I just got off our board meeting and
Hold
now
on, I'm trying to
I'm
find the
talking to
mute.
you.
There we go. All right. So anybody have anything about COVID?
I just wanted to remind everybody that COVID is both positive and negatives are still reportable from anybody who performs a COVID test. And I do not have an end date for that, but as of right now, please continue reporting all positive and negative COVID tests, antigen, and PCRs. If antibodies, we don't really need them.
Okay. And Robin, along with the reporting process, how are we doing as a state reporting to the health department? Are our labs able to get everybody, all the hospitals and laboratories able to report?
They either will report via electronic lab reporting, or they can report through their Guardian upload spreadsheet.
Okay.
Those are the options. We prefer one of those two options rather than manual data entry, as that is very time consuming. So if you are faxing and need more information about just uploading a Guardian spreadsheet, please let me know and we can get you set up with that. If you don't do very many, and this is only for COVID, we're not going to do that Guardian spreadsheet for
Everything.
for everything. We might start moving towards that for lead and did want to, possibly, just throw that out in the future. But if you're not doing ELR and do a lot of other reportable disease tests, but don't want to get full ELR, that might become an option for you later.
Okay. Does any of our laboratorians have questions for Robin regarding especially reportables? Okay. Anybody on chat?
And one more thing, if you change systems, your IT vendor system, your system must be up and running in production until that transition is made. So if you have a time frame when you are switching systems and one is down and the other is not up, you must report to us via fax all reportable diseases. So we do not have a missed reportable disease time frame. So make sure you're talking with your vendor or whoever is reporting for you to make sure that you don't turn off your feed before the other one is in process, or you don't have a plan to report otherwise.
That's a good point, Robin. Thank you. I know that LIS systems, especially some of the bigger systems, sometimes are not, or maybe even the smaller systems, sometimes are not real forthcoming with sharing information about reportables or getting the laboratory set up. I've been in those situations before. I would say if anybody is experiencing this transfer of LIS systems and are trying to work with your company and they're just not very helpful, please let us know, because I think there are other ways around it. Maybe not necessarily, but we could speak to the company, or we've got IT people that can talk their language. So if you're in that situation and would like some help, please let us know. And if you know that there is going to be a period of time, please let us know. We would be happy to help in any way we can. So anything else, Robin?
Not on that topic.
All right. sounds good. So SARS continues. I think that we still see various outbreaks, and testing continues pretty steadily. It's not like we're seeing maybe a small drop, but not necessarily a lot. So I fear that with the weather turning cold, that people are going to be more indoors. So I don't expect it to happen anytime soon. How about flu, RSV? Robin, any last minute questions about them? Do we have any positive flus in the state?
We've had a few rapids, and those that have been sent to the public health lab for confirmation have tested out negative. So we
Okay.
haven't had any. We do have one H1 that a facility had, and so that's the only on a biofire that we've had. There have been a few positive PCR panel tests, but the patient had live vaccine within the last 2 weeks. And so we wouldn't count those as cases because it's most likely due to the vaccine strain. We don't send those for confirmation, but when looking into those cases, it was determined that they did have a vaccine, and so we won't count those. And so keep that in mind. And if you do see positive flus, if you see multi-positives, usually it's positive for H1, H3, and or B, or one of the A's and a B. So if it's positive for multiple and they had a vaccine, it's most likely not a real positive disease specimen. And if you see any positive flus, we are interested in confirming those. So please get in contact with us if you want to do that. Contact your local health department or contact us or the public health lab, and we can get specimen collection kits out. If you're seeing a lot of positives on one of your rapids, let us know. We can possibly help do some confirmation on those just to make sure. And continue reporting. You're all doing a great job with the survey. Thank you so much. And then ELR, we keep checking to make sure that's up and running. So if I find anything wonky in your ELR, probably will be reaching out to you.
Right. Any questions from the field?
Karen, this is Emily from NPHL. I just wanted to note, Robin said that we did have some positive flus out in the field, but NPHL was unable to confirm. We have to use the CDC-based assay, which is very different from a lot of those rapids that are used out in the field. Perhaps you guys are all aware that the targets for a biofire panel, for instance, usually have very small targets. The ones we utilize for CDC guidance actually have significantly larger targets, and the threshold cutoff that we have to utilize is based on a significantly higher viral load requiring to be present there in order for us to truly confirm. So just because you saw it out in the field and we were unable to confirm does not mean we need to question the efficacy of your assay at this time. If we consistently see them, that's something else, but especially as the season just first starts to trickle in, those specimens that we're receiving have a tendency to have a very low viral load, especially given the climate around SARS-CoV testing. When you start getting tested at the very, very, very beginning onset of symptoms, that could indicate a very low viral load. And what we would need to confirm at the public health lab would be a higher viral load specimen.
Good point. Good point, Emily. I'm glad you're on. So thank you.
So just make sure you get a really good specimen collection.
Yeah.
Get up in there.
That is the nasopharyngeal swab, the dreaded nasopharyngeal swab. Okay. I think we're all really good at doing it. We just don't like them, right? So, okay. Any other questions for Robin? Any other outbreaks before we go on to pseudomallii? Sadie, any comments?
We don't have a lot going on right now, surprisingly. I guess I'll just update you guys on the multi-state Salmonella Oranienburg outbreak. You've probably seen it in the news already, but CDC did link the source to whole red, white, yellow onions that were imported from Chihuahua, Mexico, that were distributed by ProSource Produce and Keeler Farms. The FDA has worked to put together a list of retail establishments. The last I looked, there was only like 3 Nebraska stores on it, so it doesn't include restaurants that may have got the contaminated onions. But Nebraska is currently at 9 cases, so their traceback is still ongoing, and so that list is going to be continuously updated. But otherwise, I don't have much to update.
That's actually very good. All right. Good to know. Anybody else before we get to Burkholderia and leads? All right. I'm going to have Derry go ahead on leads because I forgot to bring up one document on the Burkholderia. So Derry, are you on the line?
I am.
Good. The table's yours.
Okay. Hello, everyone. So I'm going to talk a little bit about lead testing. Some interesting things have happened, and lead's a little bit different. Folks might not be involved in any lead screening or testing. It's a little bit different. It's non-infectious, but it's kind of interesting. A lot of children, most children in the state, need to have a lead test at ages of 1 and 2, and possibly each year up until 6 years old. And then if there's screening tests and there's confirmation tests, and there's been a couple updates in this area. First of all, there is a major recall in the manufacturer for the point of care tests, and that is Magellan's Lead Care 2 system. And the issue of the FDA recall has been the test kits themselves, not the device, but it's the test kits. And the recall has really impacted most of the test kits. There was an initial recall back in June, and then they expanded the recall back just in, I believe, September or October. We don't know how many test kits this require or this involves, but I think it's most of them. So those are for point of care tests, and that is a kind of a big deal because it represents a lot of the screening tests in the state for lead. About half of the lead screen tests are done in the point of care. So CDC, we've issued 2 HONs for this, and CDC has recommended several things. One of them is to quarantine or not use those recalled test kits. They also recommend retesting children that have been tested with those recalled test kits. And I think most importantly, the most important recommendation is to not delay or suspend lead screening or testing for children because of this recall, despite the fact that it's impacting maybe a lot of facilities. There's other ways to analyze and get a blood lead test result with capillary blood outside of the point of care. So, our message is NPHL or another reference laboratory should be able, or most other reference laboratories and NPHL can too, can analyze with higher complexity testing methods a capillary blood sample, either from a I think it's a microtainer tube, or a possibly also a blood spot paper filter card. So if any labs that are connected to clinics or in the hospitals are in this situation, the key thing is to set up that arrangement to do the capillary screening test until this recall is resolved. And the biggest thing there is, we had COVID, then we had this recall, and when kids that need to get a screening test do not get their screening test, we miss cases of lead poisoning, because a lot of cases of lead poisoning are asymptomatic, and you know, you're not going to see the effects in the child's educational outcomes or behavioral outcomes for several years. So that's why screening is very important. And so so that's a major thing. And so if you happen to do lead testing, or your hospital or clinic system does do lead testing, and they're either running into issues or delays, or, you know, any other questions, please contact either NPHL or the state health department, our lead program. And I can put my email in the chat, and let us know what issues that are coming about if you're, let's say, not able to arrange those alternative testing methods. That's, I think, the major thing we wanted to communicate, and we're in communication with CDC and the FDA, and there's no end in sight right now. I know the company is working on additional, you know, trying to resolve the recall, but I'm gonna guess that a lot of places that do lead testing are going to be unable to order test kit supplies on their next batch, because they possibly are going to be, you know, out of stock. So that's the major thing. The other important thing too, and is there's, I mean, kind of also more a bigger deal too, is the CDC lowered its blood lead reference value from 5 micrograms per deciliter to 3.5 micrograms per deciliter. That follows the population's trend. As that population goes down, what is determined of what's too high or higher than the background population level also goes down. So it's now 3.5. What that means for any labs doing, you know, screening testing, if there is a 3.5 or higher, it needs to be confirmed with a venous blood sample, and that's the ideal confirmation blood sample, venous. It's technically possible to confirm it with a capillary. That's not the recommended approach, but if it's a venous blood sample isn't possible, then that's the second best method. But a confirmation test is needed if it's 3.5 or higher. I'll stop there and take any questions if anyone has any.
There were a number of questions in chat I missed earlier, so thank you, Sadie and Robin, for taking those. But if you've got any questions for Derry, chat or unmute is fine with us. Don't hear any. So thank you, Derry. That was a lot of good information. So
yeah, and yep, no problem. And if the lab folks that are on the call, if you do know that you have a lead care 2 machine, it's worth asking about it and how they're doing testing, and what's the strategy. Are you using recalled test kits right now? What are, you know, that kind of stuff. So again, my number and email is in the chat. Let me know if any questions.
okay, sounds good. And I'll be able to put that information out too. So people who haven't been on today, and if they listen to the recording, can still get a hold of you as well, Derry. So thank you. Did I see anybody else from DHHS? Was Jeff on? Maybe not.
Hi, Karen, I'm on.
Oh, good. All right. Just wanted to check in with you to see if there was anything else.
Not at the moment. Nope. Nothing to really report here in the well, I guess one thing I'll bring up, I guess, real quick, and I don't know how much this, I guess, will affect the labs per se, but the CDC will be switching the case definition for Lyme disease coming up starting January 1st. So just kind of be aware of that. You know, they're basically making it so that states with heavy disease incidences of Lyme disease will basically be doing laboratory reporting. So they won't really be doing case investigations. I mean, they are allowed to do that if they still want to, but CDC will basically use the laboratory counts to estimates the number of Lyme disease cases. Nebraska is not a high incidence state, so our stuff, it'll basically, they're increasing specificity of what's going to be considered a case and what's not. So not a whole lot of change on our side. They are including a couple extra laboratory tests that will be allowed to be used to meet the CDC case definition, and that's going to include PCR now, as well as the modified two-tiered testing algorithm for Lyme disease. That's a couple of the new additions that'll be kind of coming out here, like I said, January 1st. But that's the main thing.
All right. We'll check back with you then. Any questions on any of the arboviruses? All right. Thank you, Jeff. Appreciate you being on. I just wanted to speak briefly about the HON that has gone out for the laboratories who do the microbiology. This was, ooh, can I make it a little smaller here? Oops. It's at 200%. I don't think we need it that big. All right. So there have been a number of questions that have arisen because of some comments that have been made in the recommendations to the laboratories. And if you look closely, some of these are very subjective. The reason we bring this up is because we've had a number of neighboring states, as we've talked before, that have actually had cases, very unusual, but there were 4 within a couple months' time. It was eventually discovered what the common source was. It was a, what do you call these, oil sprays, commercial oil spray of lavender of all things, that apparently was contaminated with this organism. So we do truly want to be very aware of this organism. And I think it brings up the bigger picture for the laboratories with microbiology, because we're talking about the LRN platform, or the flow charts that we teach. So what they're saying, the CDC is saying that any specimen that is tested on the moldy top, if there's any 16S sequencing done, if you do any testing on your Vitex, they possibly can misidentify this organism. And it could misidentify organisms such as Burkholderia cepacia, Thailandensis, the Chromobacterium violaceum, or the Orchrobacterium anthropi. And then, of course, those are the unusual ones that you know that if you get, you're going to have to do something about it. And we'll talk about that in a second. The trick comes in, or the problem comes in, when we have just, quote, Pseudomonas species, or the Acinetobacters, or the Aeromonases. Every time you have a Pseudomonas, you know, we don't want you necessarily to have to retest. But what CDC is saying is that you should consider maybe testing by another methodology, but we would recommend it be something that is very safe to do, not done on your open countertop, obviously. So you could begin with doing an LRN follow-up. In other words, follow the flow charts. If you rule it out and it truly is one of those other organisms, then you can feel comfortable that you've done 2 different methodologies. I suppose, or if you don't feel comfortable with it, or cannot do this type of testing, then we'd recommend possibly that you send it to the public health lab. But saying that, we don't necessarily want every Pseudomonas or every Acinetobacter. I think with the Pseudomonases, hopefully you can rule it out through your morphology, your colony morphology, see that it is possibly a pigmented, possibly rough, kind of that, what do you call it, a rough look that Pseudomonas, or a sheen that Pseudomonas ruginosa has. I hate to say smell it, but many times you can't help but smell the great flavor I smell. Just don't want you guys putting it up to your nose to smell it. So hopefully you can rule it out. But then I've had questions. Okay, what do you do when you have a Pseudomonas and it doesn't have any of those colony morphology or characteristics? I think that what we, in talking to some of the infectious disease doctors, have ruled out or have discussed is that you also need to talk to your physician or the ordering physician, because that you could also talk to your infection control people. They can look up to see what the history is behind your patient, see if that particular patient has a history of travel, because it's more likely now that we have kind of gotten a handle on the lavender spray. I don't think we'll see it again. I suppose you just never know, but there's other things like other symptomologies that go with having the compatible disease, the melioidosis. I'm not sure if I'm pronouncing that correctly, the melioidosis. So before you send in every Pseudomonas or every Acinetobacter, do call us, especially if you are not a microbiology lab and you get an identification of one of these more unusual organisms, the Cephasias, the Thailandenses, and it comes off your biofire. That's when you probably don't have a way to back it up and would need some reference. So please let us know. We will try to make this a case-by-case decision as to whether it needs to be sent in or not. So I don't know if that's a good answer to those people who have questioned whether they have to send these organisms in or not. But it goes with any organism that's a possible select agent. If you have not recognized it and accidentally went ahead and worked on it in the open bench top and put it on your automated machines, I mean, it just happens. We want to be careful for everybody's safety, of course, but if it does happen, it happens. And if you get that ID, it's, we just need to figure out what it is. And we want to make sure and rule it out so you feel comfortable it is the correct organism that you're reporting. So for those who have emailed me to ask this question, does that help? Any microbiology labs on this morning that, or at noon here, that would have to deal with this? Okay, that's good. Well, if you would prefer, you're welcome to email me later and we can talk more about it. So thank you for hearing me out on that one. And we'll go from there. So back to the schedule. We're down to leads. I did have another question from a laboratorian asking about what the CDC policies are on the pneumatic systems. At first, when COVID came out, it was highly recommended you did not use a pneumatic system. wherever you are. Now I understand, and please correct me, Emily, if I'm wrong on this. I don't know if Pete's been able to join us, but I think the CDC policy now is that each laboratory can decide on their own. You have to do a risk assessment first, putting it on paper to say, okay, what are the risks? You have a pneumatic system. How far does it have to go? How many specimens go in it? How many accidents have you had with it? I mean, how many breakages have you had in the system? If you have a history of a lot of them, I'd say no, you probably shouldn't be putting your COVIDs in there either. But if your system's good, if you have other reasons to say that it is not harmful to your laboratorians or your specimen receiving people, then document that on paper, and you can now make that decision yourself as to whether you can use your own pneumatic system. Any other comments about that? Has anybody gone back? And you could just raise your hand. You'll be anonymous. Raise the reaction hand, I guess you could call it, when you go down to the ribbon. There's an annotate or where is our references? Is it? Well, anyway, so I was going to say you're welcome to share if you have or have not gone back to the pneumatic system. Do I hear any questions on it? I don't see any questions in chat, so we'll go on. All right, real quickly, I wanted to share packaging and shipping because I know that there's still a lot of questions about exclusive versus non-exclusive. So my tip, a shipping tip of the month, is to be aware of the differences of shipping exclusive versus non-exclusive. Let me pull over a reference to this. This comes from actually, if you go to our website, and can you see our website on the screen? I want to make sure we can. Can I get a hands up from somebody who can see our MPHL screen?
Yeah, it's visible.
Okay, thank you very much. So to get to this, the document I'm looking at, you'll need to go to specimen packaging and shipping, and right on top, there are two different documents. It's kind of hard to separate them, but the ASM document and then the APHL Blue Book document. And that Blue Book document, once you bring it up, looks like this. I'm going to go down to, don't remember what page this was, 206. This is the, what we would call it, let me zoom out a little bit. This is the flow chart for DOT packaging and shipping. And DOT defines ground shipping. They do not, I mean, they regulate air shipping as well, but IATA is the one who defines air shipping. So there's a separate chart for IATA right here, and Postal Service, which you can, Postal Service, you can do category B, but you cannot ship category A. So in your couriers, you have to know what kind of courier you have, because as you notice, some things that are category B, if you've ruled out category A, it will then ask you, is it being transported by a private or contracted courier used exclusive for those materials? So what that means is they only ship laboratory or medical. They do not ship other things. They don't ship mail, bags. They don't ship bank items. They don't ship other patients, other things that are non-medical. So we have a couple different couriers in Nebraska. Unfortunately, our exclusive couriers right now, at least for NPHL, are they're called Lab Logistics, and also the other courier is ProMed Logistics. They are exclusive. That's all they carry. So that means if they are exclusive, that they are not, they are not required to follow the DOT guidelines. And so in other words, category B it has to be triple packaged, but it can be put into the soft-sided coolers that the carriers have. Unfortunately, the couriers we have to outstate, like On Track, they are not exclusive. So this is why we have really been pushing and stressing that this courier does need, the laboratories using this courier does need to ship in an actual category B box, properly labeled. So I wanted you to just realize the difference in this book. You can read up on a little bit more about what it takes to be a courier, exclusive courier. It's kind of down a ways. And let me move something real quickly here. I think it's right here on page 235, where it talks about what an exclusive courier is. So just that pointer for you today that I thought I'd share. And if you have any questions, feel free to put it in chat. I also wanted on our agenda, I put in something about quality assurance of specimen ships. So those who are shipping to NPHL, it is a requirement of mine to literally look at that particular box and to grade it. And not that we're pointing fingers or anything, we're just keeping track anonymously how well the state of Nebraska is doing in general for packaging and shipping of category A. So when a box comes in, our specimen processors literally have a form that they can use to grade the sample. And these are all the little picky things that we look through just to make sure it's packaged correctly. And this is a form that I'd like to share with you all in the future, so that as you go through your shipping, of course, you can follow our instructions. If you follow them step by step, you know that you'll have it all correctly packaged. But if you want other documentation, I do have something like this as well for the shipper to use, that they can use as a checklist to go through. FedEx has this. If you ever have to do category A, they have a checklist that you go through to make sure. And believe it or not, FedEx couriers use this. They go down each one and look at it. And if it's missing something or doing something wrong, they literally reject the specimen, the category A. They send this checklist with you so you know as a shipper what is wrong with the package. Now, they don't do that for category B, but you should be aware of how to correctly ship category B. So, all right, any shipping questions? I won't say much more, but I'll leave it as that. All right. Well, we can go on. And Paul, I think I saw you on. Anything on Newler we need to know, or from our specimen receiving area, our client services area?
Nothing, just trucking along.
Nope.
Haven't seen very many DHHS patients at the DBS. So there must be testing going on elsewhere, which is fine with us. We're staying plenty busy. And we have those 5 new surge staffers hired. So that's going well with the training.
Awesome.
Everything's cruising right along.
All right. Thank you. Thank you. Is anybody in the field having new alert issues? All right. Hearing none. Let me go on to open mic. So if anybody has other comments, feel free to put it in Zoom, or excuse me, in the chat. Or feel free to speak up. You're a quiet bunch today. All right. We'll leave it as that. Keep typing if you've got a question in the chat, but I thought I'd let you know that this month yet, before the November's over, I do want to send out the challenge set. I'm hoping I can get that out this week for gram stains. So laboratories who may not do all microbiology, but do gram stains, please know that that will be coming. I do hope that in December, we could possibly talk about chemical terrorism. So that might be something that we'll do here on this meeting, or I probably will be a separate meeting, to be honest with you. Anybody would be welcome, so I will get that announcement out too. I hope that starting in January of 2022, we will officially have a new packaging and shipping course that we will be teaching. It is a full day course, so unfortunately, we will probably have a full 1-day course or 2 half-day courses. I know that it's hard to get out of lab, and I'll try to hold both types, so whatever works with your laboratory to get your personnel trained. But if you do any packaging and shipping, you have to be certified with category A. And we even recommend, if you do category B shipping, that you take this class at least for the first time. And then if you need recertification, there's a much shorter method to do it. It is also online by CDC, but it wouldn't take your whole day. So I can share with you what that is. But please do text me if you need somebody. I'm not quite sure how I'll do it yet. I may just do it once a month or once a quarter. Or if you would like just your group trained, I can do that too. So let me know what your request is. And so that's packaging and shipping. The last thing I wanted to share is that I have noticed that for you out there that are techies, if you do any virtual reality, I thought this might be kind of fun. It was lab training, PPE edition, but by virtual reality. And so if you have the big headgear to go with it, I'd love somebody to try it. I don't have it, but I'd love somebody to try it. And I want to get your opinion on what you think of this new training. So there's a website that you can do. I'll have that on the on our website as well. So with that, the only other question I have for you all tonight or today is, what do we do about our December meeting? So close to Christmas, do we really want a December meeting, or shall we skip it and do January? Please type into chat what your laboratory would like to do. And I'm going to leave it at that. I'm going to open it up if there's any other questions. And I'll leave it for a couple minutes to hear what your thoughts are on next month's or January meeting too. So does anybody have last minute comments? All right. So once you put your answer in the chat, I appreciate it. And you can head out and take the last 10 minutes of your day back. So thank you, everyone. Have a great week. Bye-bye now.